Hello, this is Curtis Thompson, here to teach you about chapter 35 from Leber, tumors of neural tissue. This is almost the end of Leber. We just so you know, we've said this before, but we organized this year's lecture series around Leber so we could get a comprehensive coverage of derm path subject. But some of the chapters of Leber are better than others. So I have based this lecture, like I did my others, on a review of the Leber chapter, and then quite largely based it on the Weeden chapter, which isn't a chapter, but a component of the tumors. And the Weeden seems to have it organized maybe better for the student to be able to get their hands around the subject, but it's also a lot of information. So one thing I've done is you should have received a handout of a 2-page handout of summary. And what I do as an exercise is take notes from both books and from my knowledge, and then make a rule that it can't go over 2 pages. So I've condensed this into these notes. They have a lot of board food, like little items that you should know, and then also just little clues that help with the diagnostics. I also reorganized both chapters based on what I think you see more commonly to less commonly. So to start, neural tumors are fairly easy to diagnose, and the most important thing is to rule out other tumors. So you need to rule out melanocytic tumors. Neurotized nevi may be impossible to tell from a neurofibroma. And then importantly, malignant tumors, desmoplastic neurotropic melanoma, need to not miss that and call it a neurofibroma. Dermatofibroma is anything with a spindle cell, leiomyoma, even scar. And you can see how important this is. This is from the Leber book, but you see small spindle cells, which are positioned between the infiltrating the fat. And so your first thought would be this is a dermatofibrosarcoma protuberans. It does that, but it's actually not. It's a neurofibroma. So you have to take these into account, and immunohistochemistry helps with these. In neural tumors, we're basically dealing with peripheral nerves. So it's different from CNS neuropathology, but we always have axon or dendrites. Then you have the perineurium, which just concept-wise, no basement membrane, Schwann cells, which make a basement membrane material, and then fibroblasts, supporting fibroblasts. And also you do have vessels in there. So the components are the axons, which have the filaments, microtubules, and the immunos that stain them, neurofilament, often called NF, neuron-specific enolase. The gliofibrillariocytic protein is proven quite useful. The perineurium around it is EMA positive, and then the endoneurium is between those two, and it's kind of indistinct mucinous matrix with fibroblasts, vessels, and then even mast cells have been reported in there. So important to know about tumors from neural tumors is they originate from the neural crest, and by and large things from the neural crest are usually S100 positive. So board wise, know that it's a calcium binding protein, and we tend to think, oh, S100 melanocytes, but it actually stains a lot of other cells. So adipocytes, if you look at a lipoma or just subcutaneous tissue, when you have an S100, note that they will be positive. Chondrocytes, the myoepithelium component of sweat glands, and Schwann cells. So this is important to know that it stains more than just melanocytes. So one thing to memorize for your boards is what a Meissner or Pacinian corpuscle looks like. And it's this nice kind of onion looking central axon, indistinct axon supported, surrounded by these Schwann-like cells. So just memorize what they are and note they can be a normal finding in different parts of the body. So moving on to neuromas, one concept of about neuromas is the axon to Schwann cell proportion is about 1-to-1. So you have a lot more axons, and we have a number of different types, but the most important types that you're going to see typically are traumatic ones, and this includes the Morton's neuroma in the foot and then the solitary circumscribed, which is also called palisaded encapsulated. So it can be confusing when you see that. Polydactyly, base of the 5th digit. We can see sometimes the MEN2B syndrome has neuromas, mucosal neuromas. Think about, so that's the multiple endocrine neoplasia syndrome. RET gene, just think mucosal neuromas. Ganglioneuromas, good name because you get ganglion, and I'll show you a picture later. And then epithelial sheath neuroma, also a good name because you have epithelium and you have neural. So if we go on to the traumatic, the concept here is it is in general associated with trauma, and you see a nerve component and you see scar or fibrosis with it. So the thought also is that these solitary circumscribed neuromas are also possibly traumatic in origin, but we really don't entirely know. But these are all pretty good names. There's a lot of bad names in derm path, but it's solitary, it's circumscribed, almost. And I like that better than the palisaded encapsulated, because palisaded is hard to see, and is it really encapsulated by what? So this is a fairly good term. So rudimentary polydactyly, this is the Whedon Australian term. Just know you can see any component that would comprise a digit. So you might see cartilage, possibly even some bone, fat supporting it. You see adnexal glands, could see, even some hairs, smooth muscle, but we see nerve as part of this. So this is really not a tumor though. The epithelial sheath neuroma, I said, is a very good name. Just think clinically, memorize this: papules, plaques, upper back of the elderly, and you'll see squamous epithelium surrounding mature nerve segments. So the thing, this is really important to know about so it doesn't get accidentally diagnosed as invasive perineural invasion of a squamous cell carcinoma, because it occurs in a group of people who also get invasive squames. And then also beware, I don't have a picture of this, but beware of this similar pattern in re-excision specimens. So you may get a re-excision, and during the whole reepithelialization process, you'll get really nice perineural squamocytes that looks like invasion, and that can be confusing. So schwannoma, limbs of adults. The question is this have axons in it or not? There's kind of an ancient idea that they didn't have axons, but I think immunohistochemistry has changed that concept somewhat. We have a number of different patterns of them, and we have plexiform schwannoma, just like we can have plexiform neurofibromas. And just know, plexiform, when you see that word with schwannoma or neurofibroma, you should think worm-like. And this is worms that you can see with your eye, not through the microscope. So you may look down and see these kind of large fascicles and want to call it that, but it really needs to have the gross component to it. And these are because they're more associated with neurofibromatosis. Psammomatous, just memorize this. Whenever you see psammoma, but just think psammoma body, calcified. So it's a calcified schwannoma. Ancient change, I'll show you a picture. And then we just have a lot of reports and subcategorization of different histologic patterns, which really don't have any kind of clinical relevance. There has been suggestions of borderline malignant lesions, but this also is, these are rare, but it's based upon persistence, recurrence, rare reports of metastasis. So this is a good example of what Whedon is called a plexiform schwannoma. You can see these kind of almost trunks or cords of the cells separated by fibrous septi. This is an example of ancient. So ancient change, when you talk about it in anything, we see it a lot in nevi, is when it looks malignant. The nuclei just look bizarre, crazy, but it's actually, in schwannoma, is often associated with trauma, external irritation, and maybe in the nevi also. One thing that you can appreciate if you see a lot of these slides is it's atypia that's just too much to be malignant sometimes. So once you can set that in your eye, so they're bizarre nuclei that are just too bizarre to be malignant. So one thing you need to know about schwannomas, this is older terminology, but Antony A and B, this could end up on your boards. It's easy to remember. A is the cellular, so front of the class. A, B is the less cellular, less neurons there, so smart, not smart, A, B. And that's what this is. So the cellular areas are Antony A, less cellular areas Antony B. And then with this, we have the term Verocay body, Verocay, says body behind this, and these are the pink pink staining acellular areas surrounded by the cells. And you can, here's an example from Whedon that shows like almost a worm-like progression of Verocay body there, and this is a high power. So these don't have any significance other than that you need to know, and it's good, we need it for the histologic diagnosis. So let me show you this one case. Right here. And you can see here spindle cells, pleomorphic, a little bit pleomorphic, but not very malignant looking, set in kind of a fibrous stroma. You can kind of appreciate a little bit more cellular, less cellular areas. And there's a piece here, and then there's a piece down here that then also has a little bit of more cellular, less cellular. But this is an example of what this was called a schwannoma, but you wouldn't be entirely off calling it a neuroma. So we have these pleomorphic spindle cells, and I think it was based on these little bit of less cellular, more cellular areas. But it's pretty subtle, and you definitely, I showed this case because it's a great teaching example of one or the other, but to show you that there's overlap between the two. And when you see patients with multiple of both, you might see overlap histologically. So as we move on to neurofibromas, so the long old concept is that these have axons in them. And but that is not that important anymore. But the histology is different. You could see in the neuroma, schwannoma world, the cells were a little bit more pleomorphic, and the collagen much more fibrotic or than here. And here I always say small, monotonous, pink staining cells, spindle cells set in a delicate stroma, and then you have mast cells with it. So once again, we have this plexiform or worm-like histology, which can be present. One other things about neurofibroma, I said this before, distinguishing it from dermatofibrosarcoma protuberans and neurotropic desmoplastic melanoma is important. There's a pigmented storiform variant that has melanocytic component to it. I think some of these have ended up being what they call Bednar tumor, which is a pigmented DFSP. So you can settle all this with a nice CD34 and even an S100 if you're in the on the fence with these. So the next tumor, perineurioma, trunk extremities of young adults. They're very rare. There's kind of an old concept of extraneural, intraneural perineuriomas. And then histopathology, just memorize this picture of these onion bulbs. And they have a paucicellular with the onion bulb structures. And then this one's a little more cellular. So people talk about the onion bulbs being S100 positive, and then there's these pseudo onion bulbs. I can't say I have any experience with this, but just think of onion bulbs when you think of perineurioma. Neurothekioma. Let me just talk about this a minute while I pull this case up. So neurothekioma, generally in younger adults, females, face, upper extremity, most commonly. Now I forgot the case number. CTM 20 3942. 20 3942. The histopathology, fascicles merging with the collagen, and then we have an important immuno. So this is a not terribly uncommon lesion. You can see here a dome-shaped skin segment with this nodular proliferation of pale cells arranged in fascicles. So we cut them on end and they're round, we cut them along them and they're long. So this is a nice fascicle, as I said, merging with the collagen. So it's in this fibrotic stroma that it merges with, cytologically not very atypical, and it has this gray staining look to it. So almost like a nerve trunk there, you could almost see. And then importantly, let me just show you here what NS100 was done, which we said labels most nerve tumors. And here it's nice and negative. That's probably a little nerve twig running through there. That's not part of the tumor. We have lots of resident dendritic cells, dermal dendrocytes, and Langerhans cells in here. Know this for your boards. Langerhans cells are not only they're S100 positive. That was on my boards many years ago. So anyway, S100 negative in this, but then we did this stain, which is NKIC3, and this is the stain for neurothekioma, and that's what you need to know about this one, other than maybe being able to recognize it. You can see nice, strong staining of it. So when this stain came out, it was really lauded as being specific for neurothekioma, but now there have been publications showing there's a staining in other entities. So it's not entirely specific, but it was nice to have for this. So here's the pictures from the book, the fascicle pale cells. You can see it can be quite deep. Here's the same thing. I think our case might have been a little better. So when I trained neurothekioma, that we looked like, and nerve sheath myxoma were considered part of the same tumor spectrum, and this was just a less cellular, much more mucinous component. And you can kind of see why it was thought to be the same, because they are kind of fascicles, but they're more like blobs, I would say. You can see this lower picture has a nice, very big mucinous blob in there. So when immunos came out, particularly NKIC3, nerve sheath myxoma broke away and is now considered its own tumor. Its extremities, which also neurothekioma is upper extremities, it can be any age, and it's much more rare than neurothekioma. It likes the hands and knees. It's thought to be Schwann cell origin, S100 positive. That neurothekioma we just looked at was S100 negative, and then it has neural staining. And that's about all you need to know about that one. So granular cell tumor, good name. We have really bad names in DermPath, but the thing you need to know, granular cell tumor matches the histology and S100. So here you can see epithelial hyperplasia. So I'm assuming this is in the mouth. And then there are the cells below and on higher powered granular. So CTS 1400, let me pull that up. Granular cell tumor, usually oral and likes the tongue. It is CTS 1400, CTS 1400. Tongue, oral, but that being said, when I did a search for cases for a known session, I'm giving the answers. The cases were all from somewhere else, and you can see this one is lateral breast. You can see quite a punch biopsy with a very cellular, probably nodular. There's a bottom to it, proliferation of pink staining cells. This delicate granular, really eosinophilic cytoplasm and pretty bland nuclei. So this is a really nice granular cell tumor. So when are these malignant? They're malignant when often thought, well, people spend a lot of time trying to define what could be called malignant in this, and it's not a cytologic finding. It's greater than 5 centimeters, vascular invasion, necrosis, rapid growth. And then people have tried to assign the number of mitoses to it, but that hasn't really played out well. So if we look at the important immuno, which I already told you about, it's the right here. You don't even need to open the slide almost. See there? Really nice, strong staining S100. Here's our longer Hun cells again, probably hitting melanocytes along the basalis, and then hitting all of these cells. So very, very strongly, like if you're looking at the glass slide, you almost don't even need to pick it up to look at it. It looks so overstained. And then you think, well, could this be melanocytic? But here's an HMB45. So remember, HMB45 hits pre-melanosome, so it is a pretty specific melanocyte marker. S100 was the calcium binding protein. So that's granular cell tumor. So going on, malignant peripheral nerve sheath tumor, MPNST, things to know about it. You will probably not see a case of this. They are even deeper than the subcutis usually. And the initial biopsy is generally not done by a dermatologist. So this is a terrible tumor. Can be terrible. It can occur sporadically or in a neurofibromatosis. There's once again, like with the other neural tumors, different types based upon the histologic features. That's mostly what I think you need to know about this. I find it very unlikely you'll ask too many questions on it, but just think of it as a malignant version of schwannoma. In fact, I think it might have been called that in the past, or malignant neuroma schwannoma. So important in our life is Merkel cell carcinoma. And there is a talk of Merkel cell hyperplasia, but I can't say after sun and radiation, I can't say I have much experience with this. So it's pretty safe to assume that any kind of Merkel cell proliferation you see is malignant. Terrible tumor, 1/3 recur, metastasis sometimes up into 3/4. And then the thing you want to see here are these small blue cells. So we talk about small blue cell tumors, could be a very blastic lymphoma, you know, a high-grade tumor, and they always say Burkitt's lymphoma. But anyway, this is one of them. So Merkel cell is one of them. And the most important thing for you is that when you every time you diagnose a basal cell, you should say to yourself, this is not a Merkel cell, because the problems of missing that are so great. So what you see are small blue cells. After you have this thaw, you can see they have very indistinct cytologic features and lots of mitoses. So 21,3, 3877. I'll show you that. 21, 38, 77. Things to know about it. There's the whole AEIOU, asymptomatic, expanding rapidly, immune suppression, older than 50, and UV, trisomy 16. I'm sorry, trisomy of chromosome 6 is one of the possible board questions. There's other translocations reported, but that's the most important one. So here's a nice case we see here, deep dermal. You see those blue cells, and then on higher power, you can just see kind of these indistinct, call them salt and pepper chromatin, and they'll mold around each other. So the nuclei will actually push and kind of mold like there. You can see it. Mitoses are essentially always just immediately found, mitosis right here, which is unlike basal cell. So you can get areas of basal cells that have this kind of differentiation, and they will even stain with synaptophysin and some of these immunos we use. But if it's only focal and the other thing is overall a basal cell, then I think it should be considered a basal cell. Immunohistochemistry, one thing you see here nicely is this is actually, when you do cytokeratins, you see this perinuclear dot, or they call it the Golgi pattern. I think proteins are stuck in the Golgi. So with different cytokeratins, you can see it, namely cytokeratin 20 is often used. It's positive in this tumor, and it's not positive in like squame and basal in general. So that's usable, but even a pancytokeratin will have it. Well, that being said, this is a neurofilament, and then there was a cytokeratin 20 on this case, which is heavily, heavily stained. And this is what you call a more membranous pattern, where it stains all around it, but you can kind of appreciate dots around. So it's kind of membranous and the paranuclear dot pattern. So there's a lot of variability, and there's a lot of variability of the immunostains in Merkel cell. And sometimes you have to do all of them and still not sure. We know you should know about the polyomavirus causing this, and that there is an immuno for polyomavirus that can be used. And then importantly for boards, TTF1 is negative in this tumor, and it will be positive in lung, the same analogous tumor in the lung. Small cell carcinoma of the lung used to be called Oates cell. So those two would be histologically identical, and you'd worry this is a metastasis from the lung. So a TTF1 will, in most cases, save you with this. So that's Merkel. And then just a couple other things to show. Ganglioneuroma, I mentioned at the first. Just think of ganglion, so ganglioneuroma, so a neuroma with ganglion. These are just fried egg neurons. Just think neurons, back to medical school histology, fried eggs. Know that amoeba can look a lot like this, so we'll be careful for board tricks, that amoeba can have these kind of similar neuronal looking things. But anyway, that's a ganglion. So I talked about malignant peripheral nerve sheath tumor. A nasal glioma, just know about this. I don't have any cases. Heterotopic tissue, nose, rarely the scalp, neural tissue subcutis. And then there's a rare tumor, malignant primitive neuroectodermal tumor. Distinguish it from this, just know that it's like Ewing sarcoma and has the Ewing sarcoma translocation, for which there's a FISH probe. So I've never seen a case of this. And then there's a few other mentioned. Keep in mind neurotropic tumors, SWAME, the desmoplastic neurotropic melanoma. This is a big deal, and it's a separate discussion. We measure the nerve trunks that have perineural invasion, and it's generally those that are over 0.1 millimeters, and symptoms is a big component. So that's one thing to think about. So thank you very much for the opportunity. I hope the handout helps. If you have any questions on this lecture, or if you'd like to sign out with me, I sign out alopecias and nails, and can teach you more about alopecia if we plan it, and I can group some of my sign out cases. But thank you for opportunity to teach this year. We plan to restart this cycle, do board review, and then restart the cycle in July and repeat it again. So you should be able to get same and hopefully getting better as we do this more years, lecture series, and just get better at the same subjects, the same, go away from residency with a basic, really good derm path base. Thank you very much and have a good day.